will just rotate, and the mandible will rotate in this way by making this plan more symmetrical to the other plans. And then, once that we have studied things with the cubicity, we can transfer all our findings on the occlusogram using the digital models. I love to use digital models. I think that nowadays they give to us a lot of advantages compared to what is the usual way of working. I could spend a couple of hours of telling which are the advantages of using digital models, but you can have a virtual articulator, which is much faster than a mechanical articulator. You can study very much in details the contact points. You can see, you can make cuts of the models and see the orientation of the crowns. And in some models, not this one here, that was a rather old one, but in the most recent models, we have the possibility of having separate teeth for each tooth, and this will lead us to the possibility of making a real setup. So I really love to use digital models nowadays. And using these digital models, we import this material into our software. And we do the same things that we were doing 25 years ago. So we decide the movement of the anterior teeth. We decide the expansion. Here it's a huge expansion that is needed. An asymmetrical expansion on this side because you see it's not expanded here. It will be expanded here. The symmetry axis is set here, so we know that both midlines will have to align here, and the canines and all the teeth should be symmetrical with respect to these lines. And here you see that here are the measurements of the teeth, and these are on this column the variation. So we decide that we'll make some IPR. So this is a quite big topic, and so we are not learning this now, but just to give you an idea that treatment plans is not just saying, okay, let's do this kind of a plans, or place brackets and this wire. So that's a different way. I mean, most of orthodontists make a big mistake because they are always using the same and the same and the same way of working. And you have to imagine that the variation we have in our patients is very large. So if you are using always the same mechanics, it cannot be every time optimal, okay? What's going on? I think I need to... And as I said here, we have possibilities that were not possible, that were not available many years ago. So to study exactly the inclination of the teeth here, you see, when you start thinking to expansion on this side is not the same as expansion on this side with the different inclination of the molars. And so this can be transferred to the teeth, to the models. So here's a combination of the cubicity and the models. And finally, we can depict a treatment plan like that. What does it mean? That we have an expansion and intrusion of the segment, expansion and extrusion of this teeth here in the lower, expansion only horizontal here, this to be extruded, and this to be intruded asymmetrically in the anterior. Now we have a really very well defined treatment goal. And this is the difference I was telling you about the movement of the molars. We have a lot of rotation here, so we can tip this teeth very much. We are not allowed to tip this teeth, and there is a difference. And we cannot, I mean, the optimal treatment is not the same on the left and the right side. And nowadays, using TADs and using the many possibilities we have the capacity of saying, okay, I will do this movement on the right and this different movement on the left. So this was a very complicated case, and but what I wanted to tell you is that this case was reflecting, you remember I was telling you we needed intrusion of this group of teeth, and these were intruded, and we have repositioned the mandible, we had corrected more or less as we could. This is a non-surgical case, which is really pushing the treatment to the limit. I'm not going to discuss this case because that's not the point. The point is that great results are based on careful planning. You cannot do such a treatment without setting exactly all your treatment goals. So this was a very brief discussion on the problem of treatment planning that, as I said, is not the main topics here. And also we will discuss about the loss of anchorage. Loss of anchorage is another reason for which our treatment may fail. Actually, things are not so difficult nowadays. I mean, I remember when I was in the 90s and at the very beginning of 2000, when I was not very confident in the use of TADs, anchorage was really a limit. Sometimes I was deciding to do one treatment rather than the other because anchorage was not available to do what I wanted. Nowadays, this is not true anymore. So we can do any kind of treatment. We can set any goal because anchorage, more or less, is always available. So things are completely different nowadays. But still, there is the possibility of losing anchorage. Years ago, when you were losing anchorage, it was a disaster. Nowadays, it's something that, of course, you're not happy with that, but you can fix it. So that's the real difference. Why can we lose anchorage? Treatment plan missing or inadequate. Again, sometimes you don't think too much and you imagine you can do some movements, but remember that the possibilities of moving teeth are strictly related with equilibrium laws. So, for example, you cannot move all teeth forward. It's impossible. Unless you plan to use skeletal anchorage. So if you are not thinking in the right way, then you are not doing the loss of anchorage. It's really possible. Another thing, which is correlated with this, is the evaluation of anchorage needs. So for every movement that we do of the active unit of the teeth we want to displace, there will be an anchorage need. Anchorage need can be calculated. I mean, this is a little bit complex to do it here, but you can start with the idea that you want to move a tooth, and you can calculate the amount of needed anchorage. The amount of needed anchorage is expressed as a force. It's a single vector that is somewhere in the space, and you know that this vector will be acting to your reactive unit, and we need to have enough anchorage in order to sustain this movement that we want to do of our teeth. I will, of course, other possibilities of losing anchorage nowadays are, even if you have done a very nice analysis of your anchorage problems, you've done a proper treatment plan, you can have problems because your TAD system, it's failing. And this happens. I mean, TADs are not perfect. And so I'm going to show you a case of this kind. This is a case of mine. This is Ricardo. Ricardo, it's another asymmetrical case. Often asymmetric cases are quite complex. And this, of course, is just out of oral hygiene. And you see we have a deviation with the midlines that are severely off. We have a full class 2 on this side and a full class 1 on this side. Here we have the CBCT, and we see both condyles that are rather back in the fossa, but especially the left one, but I would say both of them. So in my repositioning protocol, I placed this material, which is Tri-Gel, for about 3 months to these patients. And I see whether the patients are comfortable, they are not breaking the material, and they stay like that. The fact that they are not breaking the material is really essential because this material is brittle. And if the patient is not consistently biting there, this will be broken. So if I see this patient, I play this material, and it stays like that for 3 months, I know that there is no dual bite. He's always biting there, 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 there. So once that we have placed the teeth in this position, in the goal, as you can imagine here, there is the need for expanding quadrant 1 and expanding quadrant 3. So this is a condition which is necessary to stabilize the mandible in this new position and correct the asymmetry of this guy. Now, what I've done as a first step, I place a TAD here, and I've connected with the molars, and using a palatal arch, I was starting to expand this part. But after a couple of months, what I've seen is that I didn't do any expansion here, and there is a even worse scissor bite on this side. You see that? What was happening, it was the TAD was not stable at all. This is what we call an indirect anchorage. And so these teeth were just moving as if the TAD was not there. So this is an anchorage loss. But nowadays, as I said, this is something which can be disturbing. You're not happy that this happened. But of course, we have the possibilities to correct this. So since we didn't have enough bone support in this on the buccal side, I placed a couple of tats here. And using this arch, which is beta titanium, this was activated in this way. This is the activation. And this is the force system that was delivered to this group of teeth. As a consequence, you will see retraction, constriction of this part, but with a rotation so that the canine will be expanded. You see, you don't want to contract the canine here. You need a lot of contraction here at the molar, and that's why we need to add to the force a large moment. And you see here that the canine was expanded a little bit, but it was expanded compared to the lateral that has no bracket, so nothing, while the molar is getting in. And after that, I've used the same tats to complete the expansion on the other side. So here are the tats, and this arch is activated in this way. So I'm not using these molars as anchorage, this teeth as anchorage, but using directly the tats here. And so I could expand this part. And now this part will be expanded since the force is more or less like that with very little rotation of the group. And now we can see what happened. So we start from here, where we had the scissor bite. Here we have the scissor bite corrected, but still the cross bite on this side. And here we are correcting the cross bite, and that was done. And now this patient with this different position of the posterior teeth is very stable with the midlines on. So it is very important that we have control of anchorage, of course, in a case like that. But of course, it's also important that we have set a very precise treatment planning. You cannot just place a continuous arch wire in a case like that and say, okay, aligners. I mean, you need to set a treatment plan. Okay. And again, I'm really surprised by people that have to treat cases like that and ask me questions about the treatment. So, could I have your point of view concerning the treatment plan of this patient? So the patient doesn't want surgery and want to align the front teeth. We plan to extract 15 and 25 and compensate the class 2. So the problem is that we start in the treatment plan by extraction. Not by saying, okay, that's the movement where I need to do for the front teeth, and this is the space I have available. We start from extraction. So that's very typical. And I think this is a real problem. We have to, especially for cases that have a rather high level of complexity, we need to reset the way that doctors look at patients, make the treatment plan, think about anchorage. I think we should do something different. Okay, but now we are going to go to the main topics of my lecture, which is mainly regarding biomechanics and problems that are set in biomechanics. One of the things that it's very important to say is that doctors are always used to start, 90% of doctors worldwide work with straight wire. And the first things they do in treatment is alignment. So what do you do when you, how many of you are doing straight wire? Raise your hands. There is a young guy over there that doesn't. But, so you see, most of you are doing straight wire. And what is the first things you do when you do straight wire? You place a super elastic wire most of the time. It depends. The size depends on the level of malalignment. So if the malalignment is very high, you will start with an ITI 012 or 014. If it's not that bad, you will use a larger size of the wire. But whatever you do in those cases, you are not deciding, you're not doing anything to decide where the teeth will be at the end of the alignment. And we call this indiscriminate alignment. But first, let me tell you what I mean by indiscriminate alignment. It's a very little animation. So when I'm here, and just to keep things simple, I take only 3 teeth, okay? If you place a wire between these 3 brackets, what is going to happen? A lot of things can happen that might be corresponding to your goal, but might be not corresponding to your goal. So maybe the most of you would say, okay, it will be a middle, something in the middle, so I will have some extrusion and some intrusion. Or maybe I will only have extrusion. Or maybe you will have all intrusion. Or maybe you will have only tipping of this teeth. And there are more. All of these movements are aligning the teeth. But it's not possible that all of them are perfect for your case. Only one is what you want. I don't think you can change your treatment goal depending on what happens here. So first you put a treatment goal and then you try to achieve it. It's not the other way around. So you place the appliance, and then what happens is your treatment goal, and it doesn't make sense. So the indiscriminate alignment, it's probably the major problem in straight wire technique. And I would say that orthodontists should learn how to make a proper alignment, which doesn't mean that every time you have to open your plastic bag, take out your wire, and place it immediately into the dental arch. If you do that, you might have many times no problem, but sometimes you will have it. So some weeks ago, I've asked to my Facebook friends to give me cases where they started with an excellent occlusion posteriorly, and they started alignment. Okay? And this is to show you that whenever you have a perfect occlusion and you start alignment, you are always doing damages. Always. The problem is the amount of damage you do, maybe not so much, so you just can, we say in Italy, close one eye on it. And so no real problem, but sometimes problems can be very large. So all this material I collected in 1 month after asking to people I mean, you know, I have a lot of followers on Facebook, and I said, guys, I need cases of this kind, starting with a very good occlusion, maybe class 1 or even class 2, but where there is a very good intercuspation, and let me show what happens when you just place an alignment wire. So this is one case where no real problem happened, but I would like you to remark something. This occlusion is not so good anymore. Of course, this is not a problem, but it's the first step. Other cases are more, create more larger problems. This is not really a problem. But it tells you that this wire did not improve occlusion, but it made it a little bit worse. See? But it's not a real problem. Oh, it's okay. This case is okay. Then we have another case where there's actually no real problem. But look at the difference. I like this very much. This is perfect. This is what we would like to get every time as class 1 occlusion. If you know that, you know, everyone is quoting the 6 keys of Andrews. Okay, everyone is saying, oh, I have to respect that. And this is one. And then what you do, you just spoil something that was already there. But this is still not a problem. I mean, no patient would complain for this. And we can close an eye on that. But you should start thinking that this system is not solving problems, but creating problems. It's a small problem so that you can say, okay, doesn't matter, but why should I do that? Is there any reason for which I should change this position to this? I know that I finish cases like that. We finish cases like that. And no one is complaining about it. But definitely this occlusion is worse than this one. Why we do this? Are we paid to make our cases worse? But it's not a real problem. So I apologize, all these cases were not mine, so people were just giving me whatever they had. And this guy gave to me this image. And here we have more alignment to be done because this canine is so much inclined to the distal. And an alignment is generating a real mess. Oh, now these teeth are aligned, aren't they? But I would be worried of this. So, in this case, what happened is that the alignment of this canine had no really any possibility to happen without having a loss of anchorage, because what you see here is a loss of anchorage. Okay? There was no space for this canine, actually not enough space for this canine. And the uprighting of this canine is delivering an intrusive force in these areas, and there is no natural anchorage against intrusive forces. Our natural anchorage are occlusive forces, but of course they are helpless against intrusion forces. Hope you follow me. So now, yes, these are more aligned, aren't they? But here I had a nice class 2. It's a class 2 occlusion. It's okay. But what is the point of changing this to this? Let's imagine that you want to make this case different. Okay? As I said, we have no space for this canine. So you might decide, I'm not saying that this is the right treatment plan, but just to make things easy and to discuss this case, which is not mine, in a few seconds. I mean, this occlusion here is perfect. Okay? So keep this, extract this tooth, and move this tooth in this area. But you should always be aware that our patients many times don't need to move all the teeth. Most of the time, we need to move selectively some teeth, and other teeth don't need any movement. And so in that case, just using an alignment wire is going to produce troubles. Small troubles that we have seen in the first two cases, so you can say, okay, I don't care, and it's understandable. Or more complicated things. Here you see that the rotation of this canine has generated an expansion here that without the intrusive force might be controlled by occlusion. What does it mean? Patient is biting here. So maybe that if there is just a horizontal force, the occlusion would help in avoiding this expansion. But as we have seen on the other side, it creates, the uprighting of the canine creates an intrusive force. And once you apply an intrusive force, occlusion is not helping you anymore. And so it's not helping you also for the expansion control. So this seems a problem. So in a case like this, now we have to work much more than what it was at the beginning of the case. I mean, I didn't do any step ahead towards the resolution of the case. I just made a treatment which has put myself more away from the final solution of the case. Okay. Now we do this slide, and then we do a little break of 2-4 minutes. From my experience, people cannot focus very much for more than 45 minutes. So after that, people. So then I leave you a few minutes without getting out of the room, just to stretch, talk with your neighbors, and then we start again. So the problem with alignment is that you are really having more and more problems depending on the amount of alignment you're doing with the straight wire. So if you have a little bit of alignment, then we had those little problems that we have seen in the first two cases. When the alignment becomes very large, it's very difficult for us to be able to predict what is going to happen. Now, what is going to happen to tooth 1-3? So to this canine. Will extrude or intrude? What do you think? Will extrude or intrude? You can answer in your mind. Will go buccal or palatal? For tooth 1-2, will extrude or intrude? Will go buccal or palatal? I mean, if you are average orthodontist, and I would say even if you are very good orthodontist, I'm sure about that, the great majority of you are just thinking that these teeth are moving in this direction. Am I right? Everyone is thinking the tooth 1-3 is going to extrude and go palatal, go in, while the lateral is going to intrude and go buccal. And I've done this game on the internet, and I know that everyone is giving this answer. So I don't really need to test you again on this. So Oscar Wilde was saying, whenever people agree with me, I always feel I must be wrong. So if everyone thinks the same things, maybe there could be some problems. And that's what happened. So actually the canine went out, but not palatally, and the incisor was was not intruded, was even extruded, besides what happened to all these teeth. So when the amount of alignment becomes very large, the possibilities for an orthodontist to predict what a continuous night eye wire is going to give are very, very limited. And think to what you were predicting for this case. And I don't believe that many of you could have predicted this. Okay? Reason for this is something that it's really hard to predict, but it's a phenomenon of, now I want to explain this, why this happened, but it's hard to predict it beforehand. So there is what we call binding here between these two teeth. You see here is just like a loop, okay? And if there is absolute impossibility of the whitest light, this works as an expansion loop. So the canine is going out, and the lateral is going exactly in the opposite direction as we would have liked to happen. But the problem is that it's so hard to predict whether a binding phenomenon is going to happen. So I can tell you afterwards, yes, that was a binding phenomenon. But besides this, the only thing you should do is to use a different way. I mean, if you have to align this area, you need to place a vertical force on this canine. You need to play an intrusive force and transversal force on this lateral. I mean, there are ways to apply a force that we know exactly, and that's the best way to predict things. I mean, if you apply the right force system, teeth are going to move according to this force system. The problem is that you have to apply something that you know. And with the continuous arch wire, it's definitely not possible. Okay, so we take this few minutes of stretching, Relaxing, I drink a little bit, and you can, but don't get out of the room. I don't know whether we can anticipate questions here, if there are any. Yeah, why not? So it's a way to...
Доктора, поднимайте руки, если у вас есть вопросы. Мы с удовольствием постараемся на них ответить. Ну что ж, пока вопросов нет, наверное, я могу поделиться с вами немного организационной информацией. Я надеюсь, все вы знаете, что завтра у нас для вас организована бесплатная экскурсия пешая по достопримечательностям Парижа. В 18:00 прямо отсюда мы отправимся на эту экскурсию. Все, кто еще не принял решение или, может быть, не знал, вы можете определиться с ответом, подойти к нам на ресепшн, мы пометим для того, чтобы заказать для вас всю необходимую гарнитуру. Поэтому у вас еще есть немного времени подумать. Подходите, мы с удовольствием всех вас зарегистрируем на эту пешую прогулку.